Hello and welcome to the March 2022 Pre-Hospital Care Research Forum Education Research Journal Club webinar. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of EMS professionals worldwide to build a body of evidence to support pre-hospital emergency care. Here in our Education Research Journal Club, we take a closer look at the latest science in medical education research. Now, we want to take a moment to thank our sponsor, Limmer Education. Through their generous support, we can make this science more accessible and understandable. My name is Megan Corey. I'm joined today by David Page, Katie O'Connor, and soon to be joining us will be Dr. Bill Toon, and we are very excited to talk about this article today. This is a great article for us educators out there. This is we're going to talk a lot about teaching and learning today, and hopefully we can squeeze it all in within the hour. We'd love to hear from you. This is an article called A Novel Algorithm-Driven Hybrid Simulation Learning Method to Improve Acquisition of Endotracheal Intubation Skills. And this is a randomized controlled study in education research. So we got great research. We have interesting discussions here about education theory. Very exciting today. So if you are joining us live, please use the chat to interact and discuss the topic with other participants and the Q&A for questions directed at the panel members. If you hear something you like, please quote, tag, and share it on your favorite social media site. You can use the hashtag EMS Research, and we love it when you tag at PCRF at UCLA, as well as our sponsor, Limmer Education. All right, let's dig in here. And if you haven't accessed this article, you should. It's, again, novel algorithm-driven hybrid simulation learning method to improve acquisition of endotracheal intubation skills. And it's a randomized controlled trial it's out of Lithuania in BMC anesthesiology. It should be open access too. I think somebody said they had a problem with a paywall at one point, but I was able to get it through open access. This is an article that has a great introduction with a lot of good discussion on education theory. It's one of the things in EMS, I don't think, if you look at nursing and the way they form their curriculum, they ground it in not just education theory, but also in nursing theory. And so everything is built around that. That's not something that we do frequently, I think, enough in EMS education. But this is a medical school study. So traditional teaching is what they talk about a little bit here. Traditional teaching of procedural skills, which is very familiar to us in EMS, even complex ones like endotracheal intubation, we know that usually involves some kind of didactic content in the form of a lecture or content, receiving the information, the why of doing the skill, a demonstration typically, and then followed by repetitive practice in a simulated environment, usually under the oversight of some lab instructors monitoring the student performance. That's kind of the classical method of teaching a procedural skill. And it's very time and resource dependent too, very heavy on the time and resources. Our goal there is often a baseline competency. So it's not mastery, typically it's baseline competency. This is, again, not always grounded in education theory, because we know from education or best practices, because we know from best practices we're spaced and distributed practice, deliberate practice, even things like deliberate practice with mastery learning. These are things, retrieval practice that we talk about on this webinar, that are some of the things that we'd like to see integrated in and promote things like retention and long-term success, and maybe even translation of that learning into better skills performance in a clinical setting and then in better patient outcomes. So often the other thing is in EMS, we have an emphasis on using experienced clinical practitioners as those lab monitors. And we have a sense of valuing the field experience, sometimes even years of instruction as a proxy for educational experience, rather than grounding the lab in education theory and best practices. This study was grounded in the concept of deliberate practice and mastery learning. So deliberate practice, if you remember, we talked about deliberate practice last time we were discussing the airway compendium. that effortful reflective practice. This is Erickson's deliberate practice model. Effortful reflective practice with feedback at each step of the way, and then standards of performance. And so standard setting is done as part of this. And then there's mastery learning, which is different than this sort of baseline, you achieve a certain percentage and that's it. Mastery learning breaks tasks into smaller tasks and then achieves mastery. The student achieves mastery at their own pace in the timeline that it takes for them to reach it before moving on to the next element. So there's no real standard time limit, and it's grounded therefore in student equity and the needs of the individual student. It's also grounded in self-reflection and self-regulated learning. So there's a lot of stuff about peer and peer teaching and learning, and I know Dave's going to want to get into that. So again, take a look at this study and look at the beginning here. Rotating roles, they actually do a lot of rotating roles and self-regulated learning. So what this research wanted to do then was to compare two models, and these are models that they have looked at. They've developed this hybrid learning model, and try to think of it as a hybrid learning model. You're going to see something that looks very techy in the paper, and it is pretty techy, but it's really not about the technology. We have a tendency to get like sucked into the technology, the high fidelity, mannequin or the high fidelity room, but it's really about the teaching and learning. So they were comparing two teaching and learning methodologies. One was the traditional, which we discussed, versus a structured hybrid learning model. And this was on groups of medical students and residents on their procedural performance outcomes. So the outcomes they were looking at were procedural performance, but it gets better. And this is specifically in endotracheal intubation. So you can see the study flow chart. We just want to go through kind of quickly who this was, and I want to bring in Katie and Dave and talk a little bit about what this, picturing this model. I'll bring up the model and what they used. But there were 100 participants originally, and they randomized the two groups. And these were fifth-year medical students. Again, this is in Lithuania at University of Lithuania. I'm going to say it wrong because I'm not looking at it. Health Sciences or Health, I can't remember the institution, but I'll correct that in a minute. 100 participants, fifth-year medical students or first-year residents, I believe, in anesthesia and emergency medicine. So you had a little bit of a mix there. And then 50 in the conventional group, and then 50 in the intervention group. That was the original allocation. After excluding, and they had, you can see some of the reasons for exclusions in the paper, and also things like, didn't want to participate. Not too many of those actually. But if they had prior training in airway skills, they could not participate. So they did exclude some people just to, again, to clean up who would actually purify kind of who would be in the two groups. And then by the time they get to the evaluation, you can see, they're finally left with the evaluation and then the analysis, which is the same numbers, 34 in the conventional and 43 in the hybrid group. The outcomes that they looked at, and actually let's talk about the two groups. They had the conventional, again, lectures, demos, practice session, 2 3-hour sessions with a mannequin, 10 students to 1 instructor when they did the demo and the first guided practice, which was 3 hours with an instructor. Second 3-hour practice was self-guided. And then in the hybrid group, so now you're over on the right side here of this chart, this was the lectures, videos, and algorithms and checklists were on a learning management system that was asynchronously delivered. So the students at their own pace would complete, the modules that involved all the content that you would traditionally get in a standard lecture. That was on the time of the instructor, not on the time of the students. So the students, would determine when they would do this. And then there was a mastery learning in there because they had to get 100% on an online quiz. So they had to take a test. I think it was 10 items, and they could take it as many times as to achieve mastery. So once they got 100%, then they would self-assemble into groups of 3 and engage in practical skills in the hybrid lab. And the hybrid lab, we'll see in a second, I'll put it up and we'll talk about what that means, but it really is an environment in which to use the same mannequins, you're using the same mannequins that they used in the conventional to practice those skills. and you get feedback, whether it's synchronous or asynchronous, either somebody you know, on a video, or someone in person, giving you feedback, depending upon when you reported to the lab, because you reported to the lab in your groups of 3 on your own time, and arrange that time, and the lab was available 24/7 with key card access. So, but again, same mannequin, same equipment, and they also had more technical educational resources, and again, I'll show that in just a second. The 3 outcomes they were going to measure then were, they evaluated the students' performance using a standard checklist, they did a post-course survey, and then they did something phenomenal, which was they went to the OR and were evaluated by anesthesiologists, blinded to who the students were, which group they belonged to. And they make sure to match the Malampati scores of the patients that they had. So that's kind of it in a nutshell. I wanted to stop here and just soak up that this whole thing. And I'll forward this slide set unless you had any comments about the participants, Dave and Katie.
Well, the methods are just phenomenal here, and there's so much to unpack. It's really kind of a challenge, and I do notice that we have a lot of international folks on this particular podcast or webinar. So if people have read this and have some inside knowledge about the hybrid lab, it'd be wonderful to hear it. Part of the methods that you just hit on that were, I think, critical is sometimes we just don't know the outcome of the study is based on maybe personal feelings about how the training was, which they did do a survey on, so that's nice. And their perception of the ease, etc. But I do really like the fact that they selected the same difficulty of intubations for these learners to be able to be measured against. So you could imagine the criticism and also the difficulty in saying, well, we're not going to just let you intubate blindly anyone. They took a look and said, you know, okay, this one meets the criteria of being the type of patient that we would want you to be able to intubate. So really good kind of even evaluation, if you will. And the fact that it was on real people, not on another mannequin, is another sort of plus. Because in the end, we don't care if you can intubate a mannequin, we care if you can intubate a human. And checklists are phenomenal, and I'm really happy that they use a checklist. And completing a checklist also doesn't mean that you were able to intubate the patient. So the is a real outcome in terms of the setup for the methods. So I thought that was phenomenal. Now, also, if we want to get into methods, I was having trouble finding out exactly. This graphic is fascinating, but in my brain was having trouble interpreting exactly what we're talking about. And so when people use hybrid learning or flipped methodology, and we're seeing people do stuff from home, oftentimes it could be anything from click through some slides, read a document, or get a lecture recorded, to something that's fully interactive and is asking you to, interact with a model. So in case people are interested, I put it in the chat, but the hybrid model was explained in a previous study. So if you're new to research, one of the nice ways that these studies build on each other is that you can describe the hybrid lab in one paper, publish that paper, and say, this is the hybrid lab, and we used it on, in this case, they used it on trauma. And so then that's described. Like, next time you want to talk about this, this is what we talk about. The next thing is, now we're going to apply it to endotracheal intubation, which is a paper we're really evaluating today. And then we can see if the same results were true in this hybrid lab for trauma as it was for intubation. And they are. So when you read the other paper, the hybrid lab focuses not just on the peer-to-peer teaching concept, but also on non-technical skills, teamwork, and I'm just reading right off the paper, this concept of formative and summative assessments for both learners and peer teachers, and these digital recordings of training sessions. So they are not just looking at whether or not you could hold the laryngoscope in your hand, or in this case, we're looking just at trauma skills or the ability to complete a checklist. They're also focused on this competency of the learner. And yeah, you can build this automaticity, which is mastery learning, that they're definitely looking for in the Bloom traditional way of thinking, but they're also looking at some very novel concepts of how decisions are made and how decisions are made within the team. And these e-learning modules combined with these algorithms to support that step-by-step learning and increased in difficulty is, I believe, kind of bringing all sorts of educational concepts into one model.
Yes.
And when people say hybrid, we use that term all the time. You have pre-recorded lecture, you have like I said, a reading you're reading a document and then you're going to show up at a lab. So it definitely, if you're an educator, makes sense to do a deep dive on exactly what are they doing and is it reproducible?
Yeah.
Because I do think that it's one thing to achieve results with amazing technology and incredible ability to get anesthesia residents into the OR to intubate, but paramedic programs may not have the luxury of that anesthesia rotation, and they may not have the luxury of having the technology to do this peer-to-peer supported and self-directed kind of hybrid. So these are if it's reproducible, they well could have figured out some groundbreaking educational models that could revolutionize the way we do teaching. That there was, we'll get into the results, but that's phenomenal. So
I'd like to bring Katie in here too, because I think we're gonna, I think I'd like to hear from her about how this could be done without thinking that, well, it's cost prohibitive, it's resource dependent. And Dennis Edgerly comes to mind. He's like one of the most creative simulationists I know, who can say, oh, this is what you do, and you can find like the things that you can do on a budget, that where it really is, what matters is the education, what matters is the teaching and learning. And so that's I'd like to know what you think, since you run simulation frequently.
Yeah, and I also, am in EMS, so I run on a budget, right? Like, I've been lucky in my career to see all of these fun things like programmable key locks and electronic door locks, but that's not been my experience when I'm in the EMS classroom. But a lot of the stuff, like the cameras they have, they're great, but you can get a similar HD webcam that just is a USB plug into a computer or into a device for less than $10 on Amazon now. So you can set this up, and Dave is also another great person. He's always got like a little bag that he travels with around the world with basically all of this setup that you can do in your pocket. You've probably seen our videos on Facebook of us using it to show research talks, but all of it for less than $10, $20. The quality might be a little bit lower, but you're going to get the same kind of experience with being able to have video recording and playback. And I would really put to people, you probably already have this in your shop. Like if you're using the iSimulate monitor, it has a video component built in. All you need is another iPad or tablet, which you probably have somewhere in your community college or your program or your department's resources. When I was in the ambulance here in Virginia, we had tablets that were just designed for triage days when we practiced triage. You could easily grab those and set it up and do a video recording session in between calls for our continuing ed folks. So it's just there, and everybody probably has access to some type of LMS. You're just not thinking about it that way. They said like theirs is equivalent to Moodle, which comes with a lot of the textbooks, or like My Brady Lab, JB Learning. But Google has those resources, and depending if you're a small program with limited budget, you probably fit into the only 10 users for free kind of situation. And I was joking with everyone earlier, most of the prices for these kinds of learning management systems are like less than $10 a month, which is more than like less money than I spend on coffee in a week. So
Yeah.
it's definitely doable.
Yeah. Yeah. That's, and I think you hit on something in terms of like what people have access to. I think we have to remember too, if you talk to any teenager who's coming out of high school, and even, I think post-COVID, we're going to start seeing some things. There are classrooms that use the OWL system. We're not talking about, private schools here. We're talking about, public, and even schools that you would think wouldn't have the resources have integrated technology into their classroom and into their learning in decent ways so that they're used to it. So what are they going to be doing coming to our programs later? And they're already ahead of our instructors. It's something they might be used to, a different type of learning too. I heard about this. There's all these simulation podcasts now too, and Sim Geeks, and the simulation in healthcare, or I can't remember the other one, the CAE one, but they were talking about these 5-minute talks now. It's kind of like TED Talks, but these I can't remember what they're called. They're a 5-minute talk, and they're little learning. Pack one small micro learning thing into 5 minutes and deliver it. And so I think that we're getting used to this kind of, here's the timeline, and then we're coming to our kind of traditional method of, you're on my timeline. I teach every Wednesday 9 to 12 in the lab. First hour is lecture, next 2 hours are where it's very structured around the institution and the teacher, versus structured around the time when the students are going to learn the best, which is, again, gets at the whole synchronous asynchronous thing that's been going on during COVID too. People are freaked out about asynchronous teaching, saying, oh, it's not that, asynchronous teaching is extremely difficult. It's a lot of work to set up, and it's very rewarding, but it's it's more than people think, and this incorporated that kind of asynchronous teaching and learning.
Yeah, meet the students with their availability, I think, was key here, because a lot of times we're like, oh, well, we can only have lab time when we have faculty, and we have to pay faculty for lab time, and that's this cost, or we don't have people. I know one of the problems is even just getting enough staffing, right? Like getting someone to come in, even if you could pay them. But one of the things that we did when I was at UCLA was we just let the students stay in the building. There was security in the building. They had security cameras anyway. So there was no worry about theft or damage. And that's an effective thing. So if you don't think that you can trust your students with an airway head, you've got a whole nother problem going on, right? So what is the concern with letting them being in the building, especially if your building has security? So our building has security. You don't need me standing there to lock and unlock a door. I could literally lock the doors. The students propped them open with trash cans. When they were done, they left. And they had to be out by the time the security left, which was 10, 11 o'clock. And I didn't stay every night till 10, 11 o'clock. I think a lot of the traditional models, and unfortunately, so a lot of programs have even reverted back to, is if there's not an instructor, the students aren't there, or this idea of homework balance, where everyone has to leave at 5 because we're not letting anyone stay late. And then that doesn't really do homework balance for people, right? If you cut off the student's ability to practice from 5 to 7, because the only time you want them to come in is extra days or only on a specific day, it's not meeting them where they're at, and it's not doing homework balance. It's the opposite.
Yeah.
So I really want to echo this issue. We keep running into the whole, we're short-staffed, we've got a lot to teach, very little time to do it in. And a couple of years ago, when we introduced the out-of-hospital scenario with the registry, we said we need to get peer-to-peer evaluation, the entire concept of the portfolio, encouraging peer-to-peer. And US instructors didn't really like that. They thought, peer-to-peer evaluation, they just won't know what to evaluate, they won't do it well. And I do want to point out that, because this research webinar is about these authors did this, and in the Annals of Surgery Education article about the hybrid lab, they're very deliberate about saying the students, it's self-directed. The students
Yes.
schedule their own time. The lab is available in a workspace. It's available 24/7. They're encouraged to schedule as many times as needed until they reach fluency or proficiency. And very clearly, and I'm quoting, during the session, each one of the team members should take the role of team leader,
Yep.
assessor, and assistant. So there's one of them is always evaluating the leader and the assistant, and they're helping each other go through the process. I also want to just point out, in terms of the deliberate practice steps, they're taking 4 phases. One in which they read the entire algorithm that they're going to do, the steps that they're going to do in the algorithm. The second is that without the checklist in front of them, they try and reconstitute the algorithm. Finally, they're doing practice of it in real time, and then they get to fluency on the 4th step. So kudos to this author group for structuring this so that it's not just, you know, at one point or another, where I work at the ambulance service, we had some mannequins and some equipment on a table, and it was there. So it was really great that it was really available, but you had to have self-starters say, well, I'm going to actually go over and try and intubate this mannequin. And mostly it just accumulated dust, eventually moved further and further away, and then was out of sight, out of mind. So here, the part of the process where we keep the learner accountable and the teams are helping each other learn becomes a very standardized format with a standardized assessment and the use of technology to track the completion of that, not just the scheduling, but the completions of the checklists. I think they did a very nice job of the setup with both capturing objective data that's clearly just precise. It's what is it that you actually did, and then also a feeling of how easy was it to do this. So these are for budding researchers who are thinking, they randomized the population. They kept it to 2 different interventions, either the control group or the group that was getting the hybrid. These are hallmarks of how to do this kind of stuff very, very well. So
I think before I move over to the algorithm and checklist, the thing to note too about the picture of this hybrid lab is, notice there's the absence of the mannequin itself in here, which I really like, that they didn't plop a mannequin in the middle of it, so that the emphasis wasn't on the mannequin. The emphasis was on how do we monitor and provide feedback to and engage in teaching and learning. So it was about the tablets that provide the extra materials, the e-learning module setup, the instructor workstation who can monitor either live or later on videotape, and the way that the cameras are set up. It wasn't about which mannequin is there, because you could adjust this for whatever. There's 2 slides here on their checklists. The checklist that they use for performing and then for assessing as well. And so this should look very familiar, but one of the things I think that we should, before we go into the results of the study, is talk about standard setting, because it's not something we do well, in my opinion, in EMS. I think that we try to by having, but I think locally, if you're teaching, whether it's continuing education or running an academy or an initial education in EMT or paramedic, a lot of people want that boxed checklist somewhere that some subject matter expert somewhere else developed, that we can say, okay, this has been vetted and developed in a standard setting, group, way out here, and not realizing. And again, I'm going to reference the checklist manifesto again. We talked about this on this webinar, and if you haven't read the Checklist Manifesto by Atul Gawande, that's a really good one to give you a new, fresh perception on what, on the use of checklists and teaching and learning specifically. He uses it in different contexts, but you can see they're fluid and developing, and they're should be focused really on the important things, and they should be usable and adjusted when they're not, and that kind of thing. But this is, they did mention a little bit about standard setting, but I think like Dave said, they referred that to a different paper of how they did standard setting for their checklist. But it should look very familiar. But something as complex as endotracheal intubation, we know, is broken down into very distinct key areas that really should not be, the students shouldn't progress until they've actually mastered that area. And I don't think we do that well. We hand a big long checklist and we say, this is your checklist, and we just go straight through it. And each one, notice, is chunked into those pieces: preparation, and then the direct laryngoscopy with the little details within them, the insertion, the verification. Katie?
Yeah, I just wanted to point out, like, what you're saying is so great. And a concrete example of this is like a number 6 on the evaluation under laryngoscopy. It's corrects the position of the patient. And then they do have next to that, like, hey, here's some detailed, like, this is what we mean when we say this, for the evaluator, so you can get some good interrelated reliability. But it's not like, if you think to one of the check sheets that everyone's probably familiar with, like your trauma medical assessment sheets, where it's like, consider stabilization of the C-spine. That's like, if appropriate in the scenario, or like controls bleeding and hemorrhage is a checklist every single time, not depending on the scenario. And here what they've done is really clearly, these are things that happen every time. Some of these are going to be dependent on the scenario. So if your scenario had nothing to do with controls external hemorrhage, it probably doesn't need to be a critical check box, because you're just going to always check it if it's not applicable. I had a conversation with people at EMS World where we asked, like, hey, if they consider the stabilization of the C-spine, if it's not applicable to the scenario, do they still get points because it wasn't applicable anyway? Or do they have to verbalize it even though it's not applicable? What training scar are we accidentally doing here because the evaluation sheet doesn't match what we're evaluating? I think that's a big thing that they avoided here by just making a check sheet that was appropriate to what they were doing.
And then they also added this, and I'm sorry, the algorithm itself is really tiny, so I blew up a few key areas so you could see what they are. But when you get the actual paper, you can blow it up and see each individual area. This colorized kind of algorithmic approach too, which I thought was kind of cool, because it's about clinical decision making and differential. We want people to be able to perform a differential. We want them to act based upon what they see. And so, but yet we need to be able to evaluate that in a way that's pretty standardized too. So it should be kind of a constant back and forth. It shouldn't be static. Our conversations and our programs should be constant about this. So,
this is the learner sheet, which is different than the evaluator sheet, right? Like, those are two different things, and we sometimes equate them really problematically, where we're like, okay, you're gonna learn medical assessment. Here's the check sheet you're gonna be graded on in a couple months. It's like, no, that's not how you learn. That's why if you look at the textbook, it doesn't have a check sheet as the beginning of the chapter, right? Like, but somehow when we do skills, we mess that up.
Yeah.
You know what I think is amazing about this particular, graphic? When we, so first of all, left to right, for the Western world that reads left to right, it's, and it's too small to read on this slide, but you essentially are seeing preparation, laryngoscopy, anatomical landmarks, ET preparation, ET insertion, ET verification, compilation. And the, so you look at aviation and culture of safety checklists, and you're looking for just the facts, just what you need when you're flying the plane, if something goes wrong, how to do this, and you're not looking for memorization. So it's interesting to see this laid out this way, and educators really could take a beat from this. I think you need to kind of clean up the OPQRST, ABCD, EFG kind of acronyms and get rid of them to just get to, when the laryngoscope is going in the mouth, what is it that we hear about? And simplify the algorithmic responses, because it's the kind of thing that you want to visually be able to go, oop, is this a decision point or not? And if it's a decision point, it should only be because of safety and critical nature, not because of style. So So I don't know. We probably need to get to results because the
Yeah.
results are striking.
Yes.
And
I
we've
just thought these were beautiful training tools to talk about
yeah,
too, and the
yeah,
methodology is really interesting. So
I
this
completely
is just a real quick thing about comparing the participants. The participants are equal anytime you're going to compare two groups. And again, the research aspects of this were just really solid. They're comparing the two groups to make sure that they were looking at like groups. You can see by gender, age, and whether they were students to residents, you know, the percentage of students to residents, which would be important. We already know they excluded people who had any kind of prior airway training, so we know they're starting pretty much hopefully a baseline, and no reason to believe the two groups would be any different. So great, we have comparable groups. That must have been a big sigh of relief. Always is a big sigh of relief that you got comparable groups and you don't have to worry about confounders there. I don't know if there's any other confounders that you guys thought of, but I you know, in terms of you know, I don't know, that could potentially affect this, but these outcomes are so unbelievably different that I can't imagine
Number
I
any
three.
thought it was interesting that they captured the weight of the student, of the learner. Don't know what that was about. You know, that sort of maybe there'd be gender differences in what, like strength or something. I think we've proven that that's really not that
Yeah.
case. So I thought it was interesting. You know, maybe there's still some perception internationally about ability of men versus women, and the weight of the learner. I thought was kind of weird, to be honest.
Yeah.
But maybe there's some perception of the ability to physically bend into the right position to.
Yeah.
These were all patients on a bed, so I think for us perhaps there is that concept of intubating on the floor, but anyway, I completely agree. The results are just like kaboom.
Yeah,
You
just
don't
like
even
it's not
need
like a 2% difference. It's
no,
like,
it's like 50% versus 92%.
and these are blinded evaluators, right? So
Yeah,
these are blinded evaluators, and then and then when you get to the live, this is a comparison in the live patient in an OR. I mean, that's,
yeah.
to me, I kind
Who's
of
not
looked and went,
checking
what?
their
Who's
equipment
not
before
paying
going to, do this? Who's not,
photography?
they're not pre-oxygenating correctly.
But that's what they
Um,
forget, right? Like that's, to me, that actually made a ton of sense because I watched the students in traditional EMS lab, like, okay, I'd pre-oxygenate, and they just verbalize it. And part of that's because we have so many students to get through, and there's an instructor, and the instructor's like, okay, just go ahead and
exactly.
verbalize that, show me the actual skill.
That's the whole thing, right? I mean, that's
Yeah.
the whole
And it
thing.
links to
The
patient outcomes.
self-directed part. These learners had to somehow take responsibility for the learning, and they had to do it themselves. And that transfer of responsibility
Yes.
clearly resulted in, I need to be able to do this versus I attended a lecture, I attended a practice, and I am being fed this by the instructor,
And I want it.
and then I'm not
That's the other thing.
responsible.
That's the other thing I'm finding is students that will say, oh, I want somebody in here who's got lots of experience. I want to hear, they want to hear the horror. Just because the student thinks that is important doesn't mean it's great for their education or retention. As a matter of fact, I'm going to throw something out here. I'm probably going to get all kinds of hate mail for this one, but I just read something and I want to look into it a little bit more, but that suggests, and this is in the medical literature, that non-physicians can teach physicians things that are not in the scope of practice of the non-physician. So a nurse teaching residents, and we're talking about the level of the resident or the medical student, central line insertion. A paramedic teaching, they bring this up specifically, paramedics teaching. This is at a recent simulation conference talking about different levels because it's about the education and the feedback on the specific procedural skill, not about the war story that you had doing that skill. And that I think also plays into this is what kind of feedback do people get in that lab? Do they get the, well, one time I was upside down in the car using my intubation, use my laryngoscope as a hatchet and that kind of thing. And then the students are like, I want somebody here who actually has intubated lots of people in the field. And it's like, well, I think, I think experience is important. At the level of the procedural skill, is it? the most important thing? Or is it
Yeah.
maybe more important later when we're trying to apply it in the real setting where the experience does matter? You know, that's different. And I don't think we've separated those two things out.
Well, clearly.
And back to Dr. Dorsett. Oh, sorry. We
Go
talked last time about the importance of what are we emphasizing in the room. It's like, what is the importance here? And Dr. Dorsett was very clear in that statement around what you practice is what you're saying is important. And so if we're only practicing like the tube goes through the coach, the tube goes through the cohorts, and not the positioning, the pre-oxygenation, like we're the ones causing the problem here.
Look at asking for the CO detector and checking it 47% of the time versus 95. You know, securing the endotracheal tube 32% of the time versus 86% of the time. It's just the results to the naked eye are just like stunning. And once again, I go back to why is it that they actually followed all the steps and did some of these critical things, is because they were responsible for making sure that they knew them and held each other accountable versus waited for an instructor to tell them, you know, how to do it. And then presumably were traditionally allowed to manipulate the mannequin a little bit, but never quite internalized the entire process and the importance of each one of the steps. So really, I think a good lesson about maybe less is more, because we think teachers, we have to tell them about it. We have to show them it. And here, I think it's important to do that in the lecture, but then really they need to take responsibility for, I'm going to have to be able to do this and I'm going to have to follow the steps. And the reinforcement of those steps becomes kind of a key factor to doing the procedure correctly and not missing a step. So, you
know, you run into this in as a practitioner if you go to teaching and you leave the practice and there's, you know, things change so quickly that suddenly, you know, certain medications are being used that you've never had practical experience with or procedures. Does that make you less of an educator, or does that make, you know, put you into a place where you should be, you know, educating at a particular level? Is it initial education when you're first learning a procedural skill, when the feedback is more important and the teaching and learning theory is more important, or important, I shouldn't say more important, but important, versus when does the whole big picture, you know, come in later? So I think that's also an element. I'm really surprised we haven't heard from Bill Toon yet. I see that he joined us, and I thought, okay, when we're saying how wonderful this is.
You would think that Bill would be like all over this, but I think it's educational violence.
When you're there,
I'm gonna go back to educational violence. We teach the way we were taught, and so we think that this is normalcy, and we have U.S. educators thinking this is the way that, you know, we do this kind of teaching. And clearly, when we actually give learners the responsibility, then all of a sudden that, you know, and I call it educational violence because I think we should be talking more about domestic violence. And when you get used to a system in which violence is perpetrated upon you and you think that's normal, then you keep repeating patterns that are unhealthy to you and unhealthy to those around you. And that is unacceptable. We've got to break the cycle, and that is what educational violence is. It's this cycle of we gotta let the teacher do their thing, and then eventually the student might actually begin to pick it up eventually. So I hope that people are seeing the tremendous shift about less is more. You gotta get them to actually embrace their learning.
And high quality feedback too. So I would like to know how much feedback came into the hybrid group, at what level, and how specific. You know, high quality feedback about the actual performance, you know, is probably the one of the key questions I had. Bill Toon, you there?
Oh, I'm here. I'm not going to do my video thing because Dave always gets upset when he sees me in my muscle shirt since I just came from the gym. So. I really do like the study. There's a lot of good things about it, and also lots of questions about it. I'd like to see it, of course, replicated because the numbers are truly small. And I'd like to know a little bit more about the operating room evaluation. You know, how many total patients did each, I couldn't find it. I just did a quick scan again. You may have seen it, but I don't know how many patients each group saw. But there's no question about it that this was well structured in the hybrid group, that it really promoted a healthy learning environment for them and provided them with the right amount of feedback to perform better than the conventional group. And you know, if you go back to Ron Stewart's works in the 80s, when he did his initial publications on this, he looked at different training methods: mannequin only, mannequin and animal lab, mannequin, animal lab, and operating room. And at the end, with each of the different groups, they found, of course, the group that had the most mannequin, animal, and operating room experience initially did perform very well in the field. But over time, all 4 groups got equal, because he hypothesized that the initial group had a lot of experience compared to the other groups. But over time, with them actually performing it in the field, they got the experience they needed to become competent intubators, you know, within their system. So what we don't know is what would happen with this. What would be different than the conventional group's overall performance over time versus the hybrid group, you know, over time? Would they just would they equalize out over time, you know, once they had enough experience and practice, if anesthesia is what they were going into? So there's some other things. It looks like they did direct laryngoscopy versus any kind of video. It would have been interesting to see more of a video, because they were relying upon novice intubators to provide them feedback regarding anatomical findings inside the mouth that only they can see. So one thing to strengthen this would be to do this with a video. Then you have the video clip of the performance that they're doing, so you have a better idea about how well they manipulate the particular blade. And that's, again, depending if they're using a standard video laryngoscopic blade versus one of the hyperacute blades, because there are different techniques that are involved. So, I mean, I could nitpick at this because it's easy to do that, but and Dave's already touched on it, when you look at the results of the conventional group versus the hybrid group, it speaks well for itself. Now we need to replicate this and make sure this just wasn't some anomaly. We need to see bigger numbers, because these numbers are not particularly big towards the total number of people that finished the process versus who started it, you know. And it would be interesting to see how to power this, you know, to get the kind of differences that you want to see.
Yeah.
And I also wonder, if you extended the hybrid training time a little bit longer, their performance would get even better. I don't know. You know, I have questions, but it touches on one of the important things I think we need to know in educating healthcare providers is what is the role of simulation? How much simulation does someone need that prepares them to deal with live tissue? And you don't want just the technical skill, you want the critical thinking skill. So there was another study that was done out of Canada that showed the difference between students that only completed 5 intubations in the operating room versus 20 intubations in the operating room. And then they were evaluated after that, you know, after that period of time. And the students that had more experience were able to manage more complications. So there still is a numbers game also involved in here. What that number is, you know, we've heard all sorts of different things in the literature. You know, when does someone reach that level of mastery where they're getting more than they're missing and stuff? So it's just very interesting. And we as EMS personnel probably need to be looking at this so we can find out what is the ideal teaching methodology for critical airway management, is the way I like to call it. And one thing, Dave, before you jump in there, he touched on it already. Are educators prepared to do this kind of education? Megan knew I was going to get to that. And I became better at teaching critical airway management after I spent hundreds of hours in the operating room, literally hundreds of hours. And I got better and understood how better to teach because I had that repetition as an educator, you know, to become truly a master at being able to translate that information. All yours, Dave.
Well, I was gonna say real quick that, Bill, the time thing that you said makes a big difference, because you're talking about spaced repetition. And if I was in the hybrid group and I knew I was going to the OR and somebody was going to judge me, that I probably would have gone to that lab like the night before or the day before. And I'm not sure the traditional group was able to do that. So maybe they were forced to be in a session a couple of days prior. So we had loss of skill and knowledge based on the amount of time from when we were practicing.
Yeah, excellent point.
I think you touched on something that is just groundbreaking, and it just made me think. You look at Ron Stewart's work, and if you haven't had a chance to look at that study, it was brilliant. It tried to get at this issue of what kind of education is really going to matter for first pass, first success on intubation in the field. But just in the spirit of really trying to throw a monkey wrench into the entire education system, you look at these kinds of results and you start to wonder if maybe our preconception of you must have 5 or, as you said, many hours and many patients in the OR in order to be proficient in a skill is actually maybe not the case.
Or to be proficient in teaching the skill, because that's what Bill was saying, and I have to say I'm not sure I would agree, unless if you're teaching crash airway or something where they need high levels of critical thinking. We're talking about first time holding a laryngoscope. Do you really need all that experience behind you to be really good at providing feedback?
Has one shot at putting that airplane into the Hudson River when he's lost both engines in that bird, and he's got 30 seconds to do it, and he didn't have a million crashes to practice on except in simulation, and he certainly wouldn't have had every one of those have an instructor coaching him on every one. It is partly his responsibility to go into the simulator and get it down to the point where he feels like he can land an airplane in water, because it's not going to happen every day. And then partly it's the checklist that says, are you going to do it right when you do it? Are you going to do each step that you need to do it right? So I might actually submit to you that mannequin intubation may actually be acceptable and effective should we have all of the other pieces of the checklist put together that we seem to skip over. So like we were saying, and Katie said, if all we care about is the tube passing through the cords, then we see all of these horrific moments of apnea and hypoventilation and hypercapnia,
Intubation hypoxia,
all of the pieces around it. And perhaps what this study is telling us is that it's the way we're actually learning and not the mannequin versus the live tissue. I think it really needs to be redone in EMS education, and we need to learn more about their use of technology, because when you look at the graphic, there's all sorts of technological toys they're using to record when the team got together and record the video of them practicing, and just how much of that is reproducible and necessary versus what are the pieces of this recipe that become that thing that made this so effective, at least in real patients. And Bill is absolutely right. I am upset with the authors for not telling us how many intubations these evaluations were done on. Is this just a single time? So did we just look at their first intubation, or is it a compilation of whatever they had that day? And some of them had more and less. But consistent performance is actual competency, not just a single moment in time where you did it one time when you first walked in on one patient. So I know that it's super hard to do already randomized trials and in education, but having a longitudinal view of this would have been really helpful to see if the long-term effect of the kids that got normal, quote normal or traditional education really began to improve, or they never quite got all the checklist pieces ever, or it took hundreds of times for them to actually adopt those checklists, which we know from practice aren't going to be reinforced every day by the clinicians who are just already fluent in doing things without the checklist.
So
I
this
guess
is the
what I'd like
16
to
item.
mention,
Go ahead.
oh yeah, that what Dave is saying too is that the tool that they're using matches the outcome they were looking for. So this is very much about the steps of intubation, not about can you intubate a Malampati 3 or 4. So they picked 1 and 2 because it's about the skills. So the mannequin you're using, if the airway is totally easy, that's fine because it's a procedural skill. But when we're thinking of things like, can you identify hives or urticaria on a patient? It shouldn't just be like moulage on a white mannequin. That should be on all different people, all different presentations of hives. So we need to make sure that when we are checklisting, like they've done something that we've really thought, is this something that is reproducible in all the situations? And a checklist driven doesn't matter what grade difficulty the airway is. So that's great. But if we're talking about like, can you identify the signs and symptoms of an acute myocardial infarction, and we only ever show them the signs and symptoms in a middle-aged white male, like what have we done?
Yeah.
So that's just me. And
now that's part of that whole critical thinking thing, and that's what I was getting at with the level of educator too, or the educator's background, the importance of the practical experience, and the importance of the educational theory, the basis of theory, and the educator's knowledge and experience. This is the overall table that just of the actions that were performed correctly as a percentage. So this is kind of the pass fail thing, I think, and you guys can correct me if I'm interpreting this wrong, but when I see them grouped in that someone got 76 to 100%, I think, okay, there we are with that standard setting. This is our standard. We want people to be above, a certain percentage of getting these actions performed. And this is, again, after trying to incorporate mastery level learning at each step. You know that you still have to have a baseline standard, and so the overall standard setting here, 91% in the hybrid group, so not 100%. And they might make that comment in the article that they, ideally you want, this is a critical skill, you'd like to see this at 100%. But the huge difference between the conventional group and the hybrid group, so 32% in the conventional versus 91%. So when they group it by, kind of passing standards, you see a big difference here. So I think that's that this is a really important chart. My assumption too, just looking at that section with the OR, they say intubations in a shift. So I'm assuming there's several, but it would be nice to know, that would be a good breakdown between the groups, numbers of intubations evaluated in the OR setting. So that would have been good. Then of course they added the satisfaction survey. And commonly you see education, I read a lot of education articles, and you see this kind of, what did the students feel? Did they feel that they've learned? Did they feel like they'd be successful? And that's always it's kind of like a patient satisfaction survey. How did they feel about their care? How did the students feel about, where they're going to go from here? Which is a piece of it, but I'm so glad the authors did all these pieces. They did this piece, the confidence of the learner, and then the standards, whether they met the standard, and then also the individual skills performance. I just thought this was a really well-rounded look at overall, abilities and a comparison between the group. Here's the thing I thought was interesting, and I know, Dave, you must have been like, oh, this is really interesting. The confidence question. After learning, I think I will pass the test successfully. Was no difference really between the two groups, at least no statistically significant difference. Which again, we do student surveys, and we say, how do you feel?
We got it. Just,
learning.
Show it to me. Oh, I got it. Just go ahead. Give me somebody's airway. I'll kill them.
Yeah. Or like, the end justifies the means. I got the tube. Too bad I, caused peri-intubation hypoxia, which we know is a real problem. Or,
Right. I hyperventilated. So, by now their blood pressure's in the tanker, but hey, I got the tube, I'm proficient.
Yeah.
You
So
know,
the
people are delusional. We are delusional about our own competence, and we just, it's like that see one, do one. I guess, do you see
yeah,
one, do one, teach one? Oh, well, I saw it done, so I guess I can do it.
yeah,
Wow.
How about I've been a paramedic for 20 years, so I'm amazing at education.
Yeah.
yeah,
Or
I resemble
my
that.
joke about the fire department is I'm on light duty, so I must be an educator.
yeah, yeah. It's got a better schedule. And then the satisfaction question, I enjoyed studying this module, was statistically higher in the hybrid group than in the other group, the conventional group. So, and I wonder what that was about. It would be nice to have a free text field to see why did you enjoy, what were the aspects that you enjoyed? Was it the schedule? Was it the time? Was it the feedback? Was it, you know, what was it? What were the differences? And it would have been nice to have some free text comments there from the students in that particular one. So I think we are heading up to, oh yeah, it's the top of the hour. So any final thoughts, Dave, Bill, Katie?
They're just wonderful notes here. I don't know if people have been
Yeah, I
able
haven't
to
been
read
seeing
some of
them.
the questions, but thank you, Michael Caduce. I do think that goal-oriented and specific types of deliberate practice, peer-to-peer review, and those were very clearly identified in the study. So, you know, we see that. And for the article from Canada, I'm going to ask that I put the Ron Stewart one in the link in the links, but I think another one was referenced, and so we can share that. We're hoping to put these on YouTube as well. But for the authors, if they're listening, because we tried to contact them, but you know, they're obviously in a part of the world that's in the middle of a conflict. So great job on an amazing study, and for us in the rest of the world, time to replicate this. Let's follow the recipe and see if we can reproduce it.
Yeah. So thank you, everyone. Bill, Katie, any final thoughts? Just a huge thank you to the authors.
Yeah, just try to replicate it.
Yeah, I think the authors though did a great job. I agree with Katie, but one little passing thing Dave mentioned about, or you mentioned about, you know, intubating upside down in the Great War stories. We did when we kept a registry of over 1,000 intubations at the, you know, the last time I had looked at it before I left that work, over 1,000 intubations in our registry. We only had one case where intubation was performed inside of a car.
Yeah. Yeah.
It just shows when you tell how where they really do things, and you tell them with numbers, they go, "Oh, really?
Oh, really?
You think
Yeah.
it happens all the time." So
Yeah.
I always like to debunk things when I can. But thanks, authors. Great job, and let's replicate it.
Yeah, great. Thank you. And thanks everyone for joining us. This is the Pre-Hospital Care Education Research Journal Club. We will be back on Friday, April 22nd, 2022, 10 a.m. Pacific, noon Central. And we do have another journal club. That's the PCRF Clinical Journal Club on Monday, April 11th. So you can join us for that. Again, 10 a.m. Pacific, noon Central. You can join us live each month. You can register at prehospitalcare.org. Big thank you to our sponsor, Limmer Education. And you can also access our archive journal clubs at pcrfpodcast.org. Thanks, everyone. We hope to see you next time.